Yeah, so what we did was Golden Jubilee Hospital is is a tertiary center where we do a lot of navigated sort of we do a lot of elective total knee arthroplasties, and one of the techniques that some of the surgeons use is the navigated total knee arthroplasty. It was one of the pioneers, was one of the consultants whom I had the privilege of working with, Dr. Frederick Picard. And what we did was we essentially followed up patients over a 10-year period, and using that data, we've done a few studies that are currently on the works of being published. One of them is this one. It's essentially we're defining optimal follow-up for computer-navigated total knee arthroplasty, and using 10-year follow-up data, and looking at implant survivorship, outcomes, and patient factors in about 1,677 cases. So total knee arthroplasty is quite it essentially improves quality of life quite a bit. It's something that helps patients with severe arthritis. With the aging population, of course, we've got increasing need for these sorts of procedures. Um, right after COVID, we had a lot of surgical backlog, especially in elective cases, which really um, amplified the amount of stress that the NHS is under when it comes to elective operations. And one thing that we know is the more patients we have, the more patients we have to follow up. And that essentially creates a lot of financial burden, and also takes up a lot of our clinicians' time. So for us, it's important to find ways to stratify, essentially risk stratify follow-up and avoid it if it's unnecessary using evidence base. Where's the research gap? So a lot of studies have been done looking at essentially implant longevity. Um, Essentially, there are a lot of registry studies that look at implant longevity. Less studies look at patient sort of reported outcomes. These are both functional and pain outcomes, and doing that in a long term as well. Limited comparisons have been made across surgical techniques too, with less focus being on navigated knee replacement. And there's a lack of evidence for optimization of follow-up duration. Um, what did we do in the study? We essentially identified the patient-reported outcome measures. We recorded it over a number of years, and we noticed when it tended to plateau. We basically compared patient factors that are affecting survivorship and satisfaction, and we used those to essentially come up with potential risk stratification for follow-up. This is a prospective study. It's a single-centered cohort study of 1,677 navigated total knee arthroplasties done between 2005 and 2011. All of our patients were followed up for more than 10 years unless they passed away or they had a need for revision, which would have been their endpoint of the study. And all patients had the Columbus implant with Ortho Pilot navigated knee replacement system. So we collected for the data collection. We essentially looked at patients' demographics, of course. We looked at their active range of motion, and that was done using goniometry. We looked at their mechanical alignment assessment, which was done preoperatively, and at 6 weeks, this was done using the hip, knee, ankle angle by imaging. We've also looked at the rates of complications and number of revisions that we had during this period as well. The patient-reported outcome measures were done using two different strategies, the Oxford Knee Score and the Satisfaction Score. The Oxford Knee Score is essentially a 48-point scoring system that the patients essentially answered as a questionnaire. And this was at the higher the points you had, the better outcomes of pain and functionality that you have. And the satisfaction score was essentially a very simple 5-point system of very satisfied, satisfied, unsure, dissatisfied, very dissatisfied. Kaplan-Meier survival was used to essentially quantify the implants of survival and Cox regression for predictors of revision in our patients. And we also used, the computer system that we had in the medical records, as well as the National Joint Registry for our data collection as well. So what we found in our patient demographic is that a mean age was 69 years. We had less than about 6.1% of our patients being less than 54 years of age, 50 and 26.6% being older than 75. 56% of our patients were female. The mean BMI was 31.9. We used the WHO classification, essentially grouping our patients into healthy weight, overweight, obese 1, 2, and 3, which was again used in the regression models to identify risk factors for implant failure and lower sort of patient-reported outcomes. And also we used the anesthetic score of ASA, to basically, we found that 75% of our patients were ASA 1 to 2 and 25% 3 to 4. So the results we've got, so the patient-reported outcome measures of OKS, preoperatively the OKS averaged out to 17.9, and at 1 year mark postoperatively, this had drastically improved to 37.7, with 48 being the highest score you can score. After 1 year, this tended to plateau. I wish I could increase the size of this screen so you can see these better, but I have to apologize, I'm not tech savvy. And the satisfaction score was greater than 90% at 10 years across the entire study, which was quite a significant finding, which was very reassuring. The patients tend to be the younger patients, the younger at time of surgery, tend to have lower sort of Oxford knee scores and satisfactions long term at our follow-up point. And obesity stage 3 was associated with lower Oxford knee score, but satisfaction still remained quite high. As we can see on these sort of diagrams here, the satisfaction levels were essentially above 90%, dipping at around 7 years to just below 90 and returning back to 90% at 10-year follow-up. The satisfaction within the age groups, we found that patients who had the operation done at a younger age, specifically age below 54.9, they tended to have lower sort of satisfaction when it came to the 10-year follow-up. This was quite significant. And as you can see, female gender was also associated with a slight lower satisfaction rate compared to male. Now looking at the looking at the Oxford knee score now, we can see on the top left side that it tends to plateau at 1 year, essentially sticking around the same level, maybe dipping a slight bit. As we can see, the Oxford knee score in patients who are younger than 54.9, again, associated with lower scores of satisfaction, of functional satisfaction and pain satisfaction, lower pain levels. And the obese patients tended to have, I think, higher weight was associated with lower Oxford knee score to begin with, but also was associated with lower Oxford knee score of functionality and lower pain levels at follow-up as well. And as we can see, females also had a lower Oxford knee score compared to males across all time points. Looking at alignment and range of motion, 83% of our patients had optimal knee alignment angle achieved at their 6-week follow-up post-operatively. Higher BMI was associated with lower range of motion, active range of motion, I must say. And females had slightly lower active range of motion compared to males as well at follow-up of 1 year. And when it comes to survivorship, at the study's endpoint, which was 17-year survival, we had 96% survivorship, quite significant. We did lose about 607 patients at that point due to them passing away. And about 98.5% survivorship when just looking at mechanical causes such as aseptic loosening and instability. The predictors using Cox regression, we found that the predictors of essentially failure was associated with younger age at the time of surgery, worsening preoperative malalignment of the knee and lower 1-year Oxford knee score. And most revisions tended to happen within 5 years of surgery as well. As you can see, this is just the Kaplan-Meier graph of survivorship. We had about 61 revisions overall in that follow-up period. And yeah, so what we took away from this was that patient-reported outcome measures tend to plateau at 1 year. So therefore, this brings in the question of whether these more patients need to be followed up long-term more after that 1 year mark. Knowing that there are some factors that are associated with worse outcomes, as we discussed, such as younger age, preoperative malalignment, and lower 1-year score of the Oxford knee score, maybe there is potential for us to stratify this follow-up. Younger age was also associated with higher revision risk, and what we concluded was that given the satisfaction scores and lower rate of revisions, the navigated knee strategy did provide consistent outcomes. Of course, this can't be compared to any other technique with this study. The risk stratification follow-up, we proposed that focusing monitoring in the first year and beyond the 1-year mark, using only following up patients who are at high risk in these cases. And also this could potentially lead to better allocation of healthcare resources long-term, whilst also providing great optimal patient care. The limitations, so strengths of the study, this is a large cohort study. We had quite a lot of patients and quite a long follow-up as well. And we also used registry-linked data, and it was a prospective study. Unfortunately, it is limited to the fact that it's a single center study. We did miss about, at 10-year mark, 41% of our patients did not respond to our questionnaire. And that was missed data there, which is quite significant. And there was no conventional total knee arthroplasty control. So this is not by any means a comparison of the different types of, surgeries, whether that's conventional, navigated, or robotic. So what we would recommend for future research, of course, this is by no means, a complete list, but we would recommend, randomized control trials. These are the highest level of evidence, as we all know. And this would be great to see how the navigation system compares to the conventional total knee arthroplasty. We can have more sensitive patient-reported outcome measures. The 12 sort of questionnaire, the 12-question Oxford knee score is quite good. And I think we will be looking into breaking down those components and seeing if there's any correlation or anything to find there when it comes to management of pain and functional outcomes of patients. But I think more sensitive PROMs would be recommended long term. And I think cost-effective analysis studies will also be quite useful as well, to assess the future for follow-up protocols. And I think one opportunity is machine learning for personalized follow-up as well, using the advanced analytics and looking at sort of the risk factors involved. And then to conclude, PROMs and satisfaction plateau at 1 year. Risk factors are for poor outcomes are younger age at time of surgery, worse preoperative malalignment, and low Oxford knee scores at 1-year mark. Routine long-term follow-up is most likely to be unnecessary in most cases. And in order for us to preserve our resources and at the same time provide optimal patient care, we can look into risk stratification approaches and coming up with better algorithms for patient follow-up that is safe. Thank you very much.